city, so they need to differentiate between the self and the non-self, like citizens and the terrorists. Okay, so they need some priming. So when we see the military response, it will be very, very non-specific. Whoever comes in contact, they will try to kill them. Okay, and it will be fast. But when we come to they should be specific actually. Specific responses, it will take some time, but for the first time. From the second time onwards, when they come in, the same identity people will come in contact with the state police, they will try to kill them directly. Okay. So just this is an example. So whatever the military forces they are doing is nothing but the innate immunity, which is very, very non-specific and fast. And when we come to the state police, that is the adaptive immunity, which is very specific and they need priming. This is the most important thing. Okay. So with this example, we'll try to move on. How the body responds to a bug. So whenever what we have discussed previously, what are the barriers we have? We have the skin, which is the biggest barrier, and other portals of entry are respiratory tract and the GI tract. So we have mucosal lining sitting there in the respiratory tract and the GI tract, so which will try to prevent entry of the bug into our system or circulation. Okay, so for some reason, if somehow the bug tried to enters into the system, what happens is we have landmines sitting there. So these are nothing but the preformed antibodies which the mother has given to the baby, which are specific antibodies already preformed. Okay, so these antibodies will try to attach to the microbe and they will try to kill the microbe. Okay, so the second landmine what we have is the antimicrobial proteins and peptides. These are called as APPs. So which are there in the plasma, which are there in the skin, in the mucosa of the respiratory and the GI tract. So these are nothing like landmines. Okay, whenever they come in contact with the bug, they will try to kill the bug there. Okay, so this is the second line of defense. So if somehow whenever this bug is entering into the system or circulation, what happens is this the microbe will try to leave its footprints in the form of some nucleic acid, cell membrane components, something like that. These are called as pathogen associated molecular patterns. Okay, PAMs. For shortcut name is PAMs. So, and at the same time, it will cause some damage to the host in the form of some damage to the cell or cell membrane, whatever it is. So, they will lead to some components, some patterns, which are called as damage associated molecular patterns. So, we have PAMs and we have DAMs. These PAMs and DAMs are recognized by our border security force, that is nothing but the antigen presenting cells. These are macrophages, monocytes, and dendritic cells. These are macrophages, monocytes, and dendritic cells. So what they will do is they have some or they have some receptor sitting over the surface, which will when they come in contact with the PAMs and DAMs, they get activated. What they will do is they will try to activate the second messengers in the cell, and out of these three cells, these macrophages, what they will do is they will try to kill the microbe also. Okay, so and at the same time they will try to give information to the reserve bench. Okay, this information will be in the form of some mediators. Okay, these are complement, these are cytokines, chemokines, acute phase reactants. So these are released into the circulation. These what they will do is they bring more blood into the site of injury. So they will vasodilation. They call more neutrophils or actual killers. Okay. So whenever these neutrophils come, what they will do is they will try to microbe. Okay. System. All the system is nothing but the immunity. So try to move and wander throughout the body. And when they go into the lymph nodes, they will try to prime the T lymphocytes. Okay, so these T lymphocytes stimulate the B cells. Okay, which are nothing but the antibody producing cells. Okay, and they will also prime the T lymphocyte machinery also. Okay, so whenever the second time when we get the same sort of infection, the B lymphocytes will directly develop into the plasma cells, and these plasma cells will release antibodies. Okay, these antibodies will bind with the microbe, and this microbe get destroyed by the macrophages in the reticuloendothelial system. At the same time, T lymphocytes will also produce some killer cells, which are called as natural killer cells. Okay, And these natural killer cells also try to damage the microbe or destroy the microbe. So this is what is like, or the whole immune response is what we have against the microbes or microorganisms. Okay, so the second set is nothing but the adaptive immunity. So overall, we have some innate responses, we have some adaptive responses. Now what we'll do is we'll go through every step. Okay, and what are the lacunae in the newborn, we'll see. Okay, the innate immunity, we have first the barriers. We have skin, mucosa, and in the newborn, what we have an extra layer is vernix. Okay, so this vernix is produced by the sebaceous glands and predominantly during the third trimester. Okay, and these vernix have a lot of antioxidant and immune properties, which will try to prevent the infections in the newborn. Okay, and as it is produced in the third trimester in a preterm baby, especially in extreme preterm, which are born less than 28 weeks, they lack this protective layer. Okay, so and so already preterm babies lack one protective layer. Okay, so that is one lacunae. And even in term babies, when we go for resuscitation, when we go for deliveries, even though we'll tell the sister to try to keep the vernix itself, if you want, just clean the eyes and keep the vernix itself. Once you leave the place, I am a comes into picture. Okay, so I am a thinks that ye log aise hi bolte hain. Okay, so they need to show the baby shining. Okay, to the parents, they'll try to apply oil and they'll to wipe off everything so that baby will shine like anything. Okay, so one practical important tip is don't wipe off it. Okay, when God has given, it has given for a reason. Okay, so coming to the skin, okay, which is the second barrier. Okay, so skin contains two important parts, that is epidermis and the dermis. Epidermis contains 5 layers. These are stratum corneum, lucidum, granulosum, basal. Okay, so when we compare a pediatric patient with a newborn with a preterm, so newborn baby have the thickness of this epidermis is lesser compared to pediatric population, and in the preterm this is very much less when compared to a term baby. Okay, and the superficial most layer, which is nothing but the stratum cornified layer, which is the like a pavement with a lot of cement and this thing which is very thick, and it will not allow entry of microbe directly through the corneum. But this corneum is not well developed in the primitive babies. Okay, so they lack that protective thing. And one more important thing is okay, can you please mute yourselves? Okay, so next thing is we have acid mantle, which is over the skin, which will try to allow the growth of the commensal bacteria, which are helpful bacteria. So whenever this acid mantle is not well developed in the newborn and in the preterm babies, they will not allow they will not give room for development of the commensal bacteria. So a lot of pathogenic bacteria might grow on the surface. Okay, and one more important thing what we do is that is iatrogenic injuries. Okay, so yes, we are doing in the best interest of the baby. We are putting lines, we are putting central lines, we are putting peripheral lines. But one thing what we need to remember is whenever we are breaking the skin, we are making tunnels to allow the microbe to enter directly, so bypassing the skin. Okay, so what we need to do is we'll try to, one thing what we need to remember is it is a protective layer. Okay, and we need to maintain the skin integrity. Okay, which is the largest organ which has a role there sitting there. Okay, coming to the respiratory mucosa. Sorry, coming to the respiratory mucosa. Okay, so in the respiratory mucosa has one protective machinery, that is nothing but your we have mucus secreting goblet cells which secrete a lot of mucus, and this whenever a microbe tries to enter, which will get stuck in the mucus layer, and we have cilia which are beating away and towards outside, so that whatever microbe gets stuck in the mucus, which will be cleared by the cilia. Okay, and we have a lot of the thing what we have discussed, the landmines. These are antimicrobial proteins and peptides also there in the mucosa. So this is whole thing helps in preventing infections in the newborn. So what we are doing here is we are intubating, we are ventilating. Okay, and these processes will hamper the mucociliary mechanism. And at the same time, if you don't give proper humidification, so the mucociliary mechanism will not work properly. So there is a risk infections, and these are there with 2 in situ and they are in the NICU. They will be colonized with a lot of pathogenic bacteria there, so they can gain access entry into the system and they can cause infections. So one practical thing is avoid ventilator induced lining. Do ventilation or CPAP as much as possible. So coming to the GI mucosa, which is another source of entry. Okay. So here important thing is the tight junctions there between the cells. Okay. They are very weak actually. So there is a lot of gap between these two cells, and microbe can directly enter through the gap junction into the circulation, and amount of APPs is less. And whenever we are not giving feeding actually to the baby, what happens is whenever we don't give feed, when we keep the baby NPO, okay, so that the noxious stimuli will get accumulated there. So there will not be gut priming, and gut will not move. Gut will be still. Whenever there is feed, gut will move. No feed, gut will not move. So accumulation of noxious substances, they damage the lining, and the microbe can directly enter from the lumen into the circulation. And as previously, the baby who is there in the NICU get colonized with a pathogenic flora. So one practical thing is you have to be aggressive with respect to nutrition, and you have to be very gentle with respect to ventilation from the previous slide. Okay. So coming to the next step, that is the antigen presenting cells. Okay. So we have certain receptors over the antigen presenting cells. These are called as pattern recognition receptors, which will recognize the patterns. What patterns? Pathogen associated molecular patterns and damage associated molecular patterns. Whenever these receptors come in contact with the PAMs and DAMs, what they will do is they will try to activate the second messengers, which will get activated and the antigen presenting cells will release a lot of inflammatory mediators. So these receptors, examples of these receptors are TLRs, that is toll like receptors, nod like receptors, integrins, and rig like receptors. Multiple things are there. Just for the sake of it, just for remembering, we can remember these things. Okay. So, but in newborns and especially in preterms, the number of receptors is less, and the number of second messengers is also less. So they lack that reception of the PAMs and DAMs. So they can't fire normally, and they can't give information properly. Okay. So coming to the antigen presenting cells. Okay, even though first thing is we have less number of receptors, first thing, and they get stimulated, they will not stimulate the cell properly. Okay, this the stimulation is less, and whenever they get stimulated, they can't directly release the inflammatory mediators. This is one of the other lacuna which newborn babies has. Okay, and our dendritic cells should prime the adaptive immune system, right? They need to give the information to the T lymphocytes. This stimulation ability is also less in the newborns and especially in the preterm babies. So coming to the neutrophils, okay, which are our major killers. So here one thing we need to remember is, though when we see the CBP report or the hemogram report, what we'll see there is total WBC count is something like 20,000, 18,000. Yes, the count is high, but that is the first or the actually working. So force is gone, the reserve force should come into picture. Whenever the reserve force is gone, the next reserve force should come into picture. But what happens in babies, that is especially in preterm babies, is the reserve is less. If the first batch dies, the second batch is not yet ready. So less reserve is there. So that is one of the important thing what we need to remember in the neonatal sepsis. Okay, and whenever the inflammatory mediators are released, neutrophils should go into the site of the injury. So they need to travel throughout the route, and they need to go to the site of the injury. But this recruitment to the site of inflammation or site of injury is less efficient, because they are not able to move properly. They're not able to move through the endothelium into the site of the injury. Okay, so there is the deforming ability is not there with the neutrophils in the babies, especially in the preterm babies. And whenever they reach to the site of the injury, their ability to kill the microbe, that is the bactericidal ability or respiratory burst activity, is less when compared to a pediatric population, and this is more problematic in the preterm babies. Okay, so one practical thing what we need to remember is, in a baby with sepsis and having neutropenia, that is always dangerous. You have to act fast, act hard. Okay, so next thing is the inflammatory response proteins or inflammatory mediators. So what are all the things we have is, one is complement. So the main role of complement is two things. One is opsonization. Opsonization means they need to call the neutrophils to the site of the injury. Okay, so chemotactic function and opsonization. And one more thing is nothing but you are killing, helping the neutrophils or helping the microbes in killing by formation of the membrane attack complex. Okay, so which needs complement C5 to C9. Okay, so the amount of complement proteins is less in newborns and especially so in the preterm babies, and their ability to kill, whenever the amount is less, their ability to kill will also be less. Next, coming to the cytokines and chemokines. Here, when even after TLR signaling, the production of cytokines is less actually in the newborns and especially in the preterm babies. And one more important and a typical thing in the newborn is we have two sets of cytokines or chemokines. Okay, one is pro-inflammatory, one is anti-inflammatory. God has given this because whenever there is a fire, you need to stop the fire. Okay, otherwise, yes, fire for some time is okay to kill the microbe, but if it is beyond our control, what happens? It will kill even the self cells also. Okay, so somehow you need to contain it. Okay, so that's why God has given fire and along with it water also. Okay, so we have two sets of cytokines. One is pro-inflammatory, another is anti-inflammatory. TH1 is pro-inflammatory set. TH2 is anti-inflammatory set. What happens is in the newborn and in the fetus, TH2 response is more when compared to TH1 because they the immune regulation should be in control because they are growing in some other's body. Okay, so they can't directly fight against them, so that more damage will takes place. So that is a protective mechanism. That is why your fetus will not get rejected by the mother. Okay, or fetus will not reject mother actually. Okay, so anti-inflammatory is more than pro-inflammatory. This is one typical thing which is in the newborns. Next is the acute phase reactants, which are produced by the liver. The commonest example is the C-reactive protein, which are predominantly used for the diagnostic thing, but their role is still there in the inflammation in calling the neutrophils and the reserve forces. So coming to the passive immunity, so we newborn babies get passive immunity from the mother in the form of immunoglobulins. So IgG cross, rest all will not cross, and this crossing predominantly takes place after 20 weeks. Okay, so and the importance is whenever the immunoglobulin G amount is less than 100 milligram per decreases by 100 milligram per deciliter in a newborn, the risk of infections will increase by 15%. Okay, that is as much important as possible. Okay, and here important thing is the preterm babies will not have enough time for the transfer, one thing, and the IUGR babies have impaired placental transport. So overall amount of immunoglobulins is less in the preterm babies and IUGR babies, so that they are prone to infection. And whenever it is less, decreased by 100 milligram per deciliter, the risk of infection is increased by 15%. So the problem is we don't have IgG. Okay, but the remedy is what we can do is if there is no IgG, what you can do is you can give IgA. Okay, so IgA is lot of IgA is there in the express breast milk. Okay, if you give colostrum properly, if you give express breast milk properly to the baby, okay, so something is better than nothing. Okay, even though there is no IgG, what we can do is we can give IgA to the baby. Okay, which can help in fighting the infections. Okay, so next coming to the antimicrobial proteins and peptides, which are our landmines. Okay, so there are a lot of substances in the body like BPI, bactericidal permeability increasing protein, lactoferrin, lysozyme, PMN elastase, cathelicidins, defensins, secretory phospholipase A2. Okay, so all these are there in the plasma, in the skin, in the mucosa, both respiratory mucosa and GI mucosa. Their role is whenever they come in contact with the microbe, they need to kill the microbe and get induced so that more number of APPs will develop. Okay, but this expression is gestation dependent. So the lesser the gestation, the lesser will be the amount of APPs, and they should get upregulated actually whenever they come in contact with the microbe. Okay, so more number will be there against infection. But babies in preterm babies, what happens is upregulation will not be there. So whatever is there, they will get lost in the battle, and after that, no other forces will be there. Okay. So as babies are not having this adequate amount of APPs, if you give express breast milk which contains a lot of immunological factors, there will be something going to the baby. Okay. Coming to the adaptive immunity. So which is we have two components of adaptive, that is cell mediated immunity and humoral immunity. Okay. In cell mediated immunity, the predominant thing is T cell driven. Okay. This T cell driven immunity is not from to the baby, actually develop this sort of immune response. Okay, And this T cell immunity or T cell responses are skewed towards Th2, that is more of an anti-inflammatory. So in T cells also we have two types, that is T regulatory and T cytotoxic. So in babies we have T regulatory more than your T cytotoxic, because baby should survive in the mother, right? Okay. And even whenever they come in contact with the microbe also, we have the natural killer cells or cytotoxic cells will not have that ability. That cytotoxic ability is poor actually. This is one of the important lacking. Next, coming to the humoral immunity, which the main component is the B cell, from which the plasma cell develops, and from the plasma cell antibodies are released. Okay, so the ability to mount the antibody response in the form of IgG is very much less in the newborn, and especially so in the preterm babies. Okay, so compared to IgG, IgA and IgM will develop, will increase rapidly, but they are not very effective in fighting against infection. Okay. So the practical thing what we can do is we can give express breast milk which contains IgA, okay, which can help in fighting the infection. Okay. So to summarize, we have age dependent susceptibility. Yes, we can't do anything with that. That is because of immune system ontogeny. Immune system is still developing. Okay, we can't expect more from an immature system. Okay, and every component of the immune system has lacunae. We need to identify that and we need to accept that actually. Okay, but what we can do from our side, we can avoid iatrogenic injuries at the entry sites. Okay, we need to remember that they are there for a reason. Vernix is there for a reason. Skin, we need to maintain the skin integrity, avoid a lot of pricks to the babies, maintain the integrity. And for the respiratory mucosa, try to be to do as gentle ventilation as possible. And with compared when we come to the GA mucosa, try to be as aggressive as possible with respect to nutrition. What here I have done is I have simplified a lot. Okay, but it is in reality it is far more complex than what I have told now. Okay, thank you.
Thank you, Venkat, for making a complicated topic into a simple pictorial presentation. And I'm sure a lot of things need to be looked back again, because I think this 30 minutes was not enough for people to understand the PAMs, DAMs, and the cytokines and the interleukins and integrins. But this presentation is going to be very useful for most of us to re-understand the defense mechanism of the body, not only for newborns but across the body spectrum, across the spectrum. You rightly pointed out that we have newborns have innate immunity very poor, and that is the one which is damaged the maximum by the iatrogenic interventions. Iatrogenic, I mean right from delivery room till the baby is out of the NICU, and also in the home atmosphere, like taking care of the umbilical cord or the eyes and bathing. So apart from that, you did maintain that the other important markers, the landmines, that is the PAMs, DAMs, and the other proteins which are needed to bind to these microbes and give a clue to the immune system that something is going wrong or also deficient. So all the spice or the SPIES spice are lacking in the newborns. So that is causing that is also causing a lot of problems. But the spice is best available from the mother's milk. The mother's milk is the one which gives all these proteins, which will enhance the baby's immune system and gives the right messages to the body to act at the right time. Yes, among the adaptive immunity, the cell-mediated immunity is reasonably well developed, but the humoral immunity is not well developed, especially in preterms, because less transfer of IgG from the mother to the baby. Yeah, but again, there you have IgG coming from the mother's milk to help you in protecting at least from the GI tract. There are many interventions which are done for the skin, for the respiratory mucosa, and also for the GI, which are the commonest routes of spread. And in each one of these areas, we need to understand how do we prevent and how do we enhance the immunity to ensure that we do not cause problems for babies. So one side, these babies have a poor immunity, and other side, they require a lot of interventions which will breach the barriers and cause problems to the immunity. So I think they are at a double disadvantage because they are on a cliffhanger. They bend this side, they have a problem. They bend that side, they have a problem. So they need to work. We need to work closely with the baby to ensure that their path is safe. There are some questions for you, Venkat. So
Hello.
Complement innate system, classical autolectin, yes. Frequent breast breaching of physical barriers, undesirable stimulus to the umbilicus, reducing gastric acidity, recurrent aspirations. Yes, Dr. Subramaniam has given his viewpoint on improving the immunity in the adaptive immunity.
Hello.
I don't see role of probiotics. Dr. Ali Melu wanted to ask you on role of probiotics, how they will enhance the immunity.
Okay. So actually, in while discussion we went through one of the receptor, that is toll-like receptor. Okay. Actually, important thing is in the GA mucosa we have this toll-like receptors. So if these receptors gets activated with the pathogen, we have inflammatory mediators are released. At the same time, if these receptors gets activated by the commensal bacteria or good bacteria, more of an anti-inflammatory healthy mediators will be released. So the more the healthy, the more gut will be healthy, and the risk of infections will be less, risk of inflammation will be less. Okay, so the probiotics actually mechanism of action is at the level of the TLRs. Okay, so it is towards anti-inflammatory and towards healthy mucosa against the, and it will not allow the pathogen to come in contact with the TLRs again. It will sit there itself. That is how it will help probiotic.
So one is it will bind to the microbe. Second is it will it by itself will stimulate the anti-inflammatory response rather than the pro-inflammatory response. It will prevent the binding of bacteria to the toll-like receptors, which is pro-inflammatory toll-like TLRs. So any other question? Otherwise, so thank you, Venkat. I think it was an excellent presentation.